Okay, we're right at the top of the hour. I think we'll get going as people are joining. Welcome everyone to our first Friday, April webinar. The title today is COVID-19 Critical Lessons Learned from a Global Pandemic. I'm Rob Murphy. I'm the Executive Director for the Institute of Global Health, who's sponsoring this. I'm also the John P. Fair Professor of Infectious Diseases and Professor of Biomedical Engineering here at Northwestern Feinberg. Thank you for joining us today. Please take a moment also to follow us on Facebook and Twitter, hashtag FSM Global Health. In addition, we welcome you to become an Institute for Global Health member to receive, if you're not one already, to receive access to specialized resources and services that support research infrastructure. For more information, please visit our website, very easy address, globalhealth.northwestern.edu/members. Today, we are very thrilled to have with us Dr. José Ramón Fernández-Peña for a very timely discussion on the important public health lessons that have been learned now that we're a year into the COVID-19 pandemic. A little bit about Dr. Fernández-Peña. He's Director of the Health Professions Advising at Northwestern University, where he leads the university's effort to support students interested in pursuing careers in the health sector. He's the current president of the American Public Health Association. Previously, Dr. Fernández-Peña was an associate professor, now emeritus, and the associate chair in the Department of Health Education at San Francisco State University, where he worked on the health workforce diversity and cross-cultural communication in health. Prior to this, he worked at the Mission Neighborhood Health Center in San Francisco as director of health education, where he managed the health education programs in the HIV, adult medicine, women's and teens clinics. He's also the founder and executive director of the Welcome Back Initiative, a program to assist immigrant health professionals already living in the US through the necessary steps to enter the US health workforce. There will be time for questions following the presentation, and there's also going to be a period in the middle of the presentation where you can personally ask questions, and we welcome you to submit. When you do submit your questions at the end of the session, please use the Q&A feature that you see on at the bottom of your screen. And now, ladies and gentlemen, Dr. Fernández-Peña, please take it away, sir. And thank you for joining us today.
Thank you so much, Rob. Thank you for the invitation to speak with you today. I am oftentimes told that I am soft-spoken, so if you cannot hear me, please let me know. I can speak a little louder. And yes, my name is José Ramón Fernández-Peña, and I'm really grateful for the invitation and for the opportunity to speak with you today. As Rob mentioned, I'm currently the president of the American Public Health Association, while I also work at Northwestern as director of Health Professions Advising. For the purposes of today's presentation, I'm wearing my APHA president hat. So my background is my purple Northwestern, but my slides are all going to be appearing on the APHA format. Just a note before starting that, like most of you, I spend way too many hours on Zoom, on Teams, and on all sorts of other video platforms that I didn't even know existed. And one of the many things that I've learned this year is that there is nothing more boring than sitting through endless presentations where someone's showing a PowerPoint presentation and I don't have a chance to participate. So today I am going to ask you to join in and sharing your own experiences, your own thoughts, and the lessons that you have learned in this past year living through a pandemic. Okay, I think it's important that we build a body of knowledge of the human aspect of the pandemic in addition to the medical data, the statistical data, and the public health data. So with that, let's just start that roughly 15 months into this pandemic, this is where we are today. And the numbers are not only not small, their numbers are very alarming. I can personally count 8 deaths and over 30 cases among my family and friends. So when I look at these numbers, I don't see numbers. I very much see faces as well. I see people that I have known and that I have loved. And it's a reminder, almost a PTSD experience back for me to the days of the AIDS pandemic, the first pandemic of my life. So let me take you back a couple of years, 40 years to be exact, when in June of 1981, the MMWR reported this pneumocystis carinii cases in 5 young, previously healthy gay men. So I find that there are striking parallels between these two major pandemics of my life, HIV and COVID. And some of the things that I find are that when I arrived in the US in 1985, and I was confronted for the first time with a combination of fear, anger, frustration, all things that motivated me to find how an outlet for all these feelings and emotions and intent. And I discovered this group in New York City, Gay Men's Health Crisis, which was an organization that was already 4 years in operation by that time. And they were actually doing something to prevent the spread of HIV, to manage or offer case management services to people with HIV. And they had a big role in advocacy work. At the time, they had the top-notch prevention programs, prevention health education programs primarily. And their role in advocacy was very important. First, to me, I came from a country, from Mexico, where advocacy work was not something we did. It was not something we knew about. So this whole notion that I could go as a member of the board of directors to Washington, D.C. and sit in a legislator's office and request funding to develop programs and implement programs to serve the population that were mostly affected by HIV was a completely new experience for me. It was a call to action at a time of governmental neglect and inaction. It was also a vacuum of leadership that ultimately led to the deaths of 32 million people around the world. Today, about 40 million people are living with HIV, and while we still don't have a vaccine nor a cure, HIV disease can now be treated via a combination of medications and has pretty much become a chronic manageable condition. But some of the most important lessons I learned during those days, those years, include the value of prevention and advocacy. And these two pieces have guided my work and have inspired me and sustained me during the time we're living now. So the obvious thing is, how is this relevant today? And I will bring us now to 2019, December of 2019. Roughly 15 months ago, we began to hear reports about this new virus. And within a month, the WHO had declared a global health emergency. By February, the first death outside China, it was reported. And by the end of the month, there were deaths reported in Europe, in Latin America, and in the United States. Sadly, I think that the response to this new threat was in many ways similar to the response of the first reported cases of that other virus 40 years ago. Because of the tragic lack of preparedness, the urgent need to treat, and these are some of the things that I'm going to be talking about. So first of all, because of this tragic lack of preparedness, we confronted the immediate medicalization of a public health crisis. The urgent need to treat patients consumed all the energy and resources available in the early stages of the pandemic. This is very similar to what happened in the 80s in regards to HIV. The resources went pretty much to treating the dying and to attempting to develop vaccine and medications to treat the disease. There was really no talk or no effort, certainly early on, to talk about developing a national prevention strategy. And I'm talking about a primary prevention strategy where we could have focused our efforts in providing the information with a clear and consistent voice about how people could prevent becoming infected with the virus in the first place. I would think that the conversation we have been hearing in the past month or so about vaccine hesitancy goes also along these lines. A lack of coordinated messaging has been very instrumental or very problematic and has further fostered confusion in this realm. I think that the lack of diversity in the health workforce, the lack of this cultural and linguistic parity continues to put the population at higher risk. The small number of providers at all levels that come from the communities most at risk creates barriers to the treatment and reinforces mistrust in service agencies. The need to develop culturally and linguistically appropriate prevention programs is equally hampered, as is the implementation of effective contact tracing programs. And this impact, again, is especially severe in the context of mental health services. We have seen, of course, that during the pandemic, the need for mental health service has been exponential, be it because of the conditions of isolation or individuals that were in need of mental health services and were not able to obtain them, or the growing stress because of the economic impact of the pandemic, or because individuals that may have been on, on recovery programs or things like that. And a critical piece about mental health services, as I'm sure you all understand, is that when you don't have mental health services in the language that the population uses, you essentially don't have mental health services. So the cultural and linguistic parity in this space is particularly important and relevant. The problem with employment-based insurance is the same with COVID as it was with HIV. The problem with living with a country where more often than not access to health services is contingent upon employment has been again exposed as one of the big fundamental tracks in the structure that facilitates the spread of a pandemic. And last but certainly not least, I think it's important that we call and understand the relevance of racist practices and structures and how those fuel as well the spread of the pandemic. During HIV, homophobia was the main driver in the early days of HIV. And today we see how, again, we are forced to face the fact that there's racist practices in place that prevent people from having equal access to services. So this is a very rough background, but I think it provides the parallels that I want to point out between two pandemics. So where are we and what have been some of the learnings for me throughout this? And I think that the first and most important piece is the preparedness. The lack of preparedness. In order to plan coordinated responses at the national level, there needs to be a well-funded unit that can effectively lead a federal response. And by that I mean from the availability of PPE and syringes to all the logistics involved in the mobilization of people and equipment from one part of the country to another. The second one I was talking about just a minute ago is that despite the many efforts at many levels, the health and public health workforce continue to suffer from lack of diversity. And this lack of diversity continues to be a barrier to direct services and to the development of cultural and linguistically effective prevention strategies. Excuse me. A fundamental piece of the problem this past year, I think, is the lack of evidence in the policies or the decisions that were made at the federal, the state, and sometimes at the local level. So the imperative to produce and share evidence and data to support this policy decision making is once again emphasized and highlighted. It's not only health policy, but it's health in all policies. And without, I'm going to talk about this next. So the critical role of leadership and the need to speak with one voice in times like this, I think I don't need to point to anybody what we have seen and what we have been through. But this unchecked ability to question evidence, or the unchecked ability for anyone with a cell phone to put out a message that was not checked by anybody, that has no basis, but can spread like wildfire via Twitter or Instagram or something, has created a terrible, terrible, terrible situation, not only in the United States, but in many places. I am from Mexico, and I can tell you that I get at least 3 or 4 messages a day from friends and family in Mexico saying that they read this, that they read that, that the message was this, that somebody said that the priest said this, that the cousin said that the teacher said this. Our inability to speak with one voice throughout this, I think, has done tremendous damage and will bring to fore a number of things down the line. I think that one of them, or one of the very important ones, is that the quest for health equity and social justice is alive and well, and we all need to be players in this space in whatever is our level of ability. So I would like to pause here for a moment, and I want to hear if anyone in the audience would like to share any additional experiences they have learned throughout this pandemic up until now.
Rob, you have your hand raised. You can
Yes.
go ahead and start.
I've actually never seen the demonization of the medical experts like I have in this thing. I mean, it's the fact that Anthony Fauci has to have 3 bodyguards when he goes outside his home. And I mean, literally everyone working in the field has had hate mail and death threats and stuff like that. I mean, I trained in the HIV epidemic. I thought that was bad. This is actually much worse.
Right.
What do you think of that?
I think it's tragic. I have friends who are directors of public health departments or health commissioners and are receiving the kind of death threats that you're saying, either in the mail, through their social media, or on television, or on the airwaves of other sorts. I mean, the demonization is a great word of scientists, especially in the field of public health, is alarming. Is alarming and concerning, because I don't know how we come back from that. I don't know how we come back from that in an environment that is so divided along political lines. And that's a much larger conversation. But I think that the importance of being aware of that, and the importance of being proactive about that. So I think that we sometimes don't think of ourselves about advocates in the field of health or public health, even though we are advocates for our patients or for the communities we work with. What is our role, or what can be our role in engagement with our elected officials? What can we, or should we be asking of our elected officials? How can we, or do we provide expert testimony at different events? I have a very good colleague, for example, that was providing expert testimony in Texas on a court case that was involved in about the legality of requiring mask wearing during the past election. So was it okay? Could the county require that voters wear masks? So, I mean, it's from the absurdity of requests like that to much bigger pieces. So I think that it's a very piece that we need to be mindful of, and that we, I think, need to be actively participating is in the advocacy space.
I see another hand raised. Judith Maisel, you can unmute and share.
I think many thanks to all my friends at Northwestern. These issues are so complex. In the beginning of this, I thought that our schools, of course, need to do a better job. But when I'm looking more broadly at this, and I'm seeing such a lack of respect just across all sorts of disciplines, starting with our climate, starting with our elected officials, starting with our lack of respect for each other. All we have to do is see how we treat each other on our TV programs. So I really think that it's not going to be up to the government officials. It's not. It's going to be up to each one of us and what we can do to make this a better world. So I'm proud to say that I'm here at Northwestern because I work on advocacy with Dr. Chandler and Dr. Stoop in the Malnati Brain Tumor Institute. And this has given meaning to my life. So I just feel that a lot of people are sort of missing that in their life. And I feel fortunate that I have found this way to make sense of all this. In addition to which, if we go back to some of our previous campaigns here in America, the non-smoking campaign, the Got Milk campaign, those were very, very active campaigns. We saw the posters all over, everywhere about this is what a smoker looks like. I'm sure some of you are old enough to remember the Got Milk campaign. I have seen nothing about promoting this in a national cohesive way. And we have so much talent here. Our PR companies, our marketing companies are just fabulous here. And there's been nothing about getting people on board with this.
Thank you for that comment. And I very much agree with everything you're saying. I think that it's not something we leave passively to our elected officials, but that we all need to play a role in this matter and how we do and how we communicate with each others. I'll tell you, for example, I live in a small building with only 20 units, and I noticed that some of my neighbors walk around the building without masks or anything. And so I try to have a conversation with some neighbors, and sometimes it's possible to have a conversation. Sometimes it's perhaps a provocation. So in those cases, I resort, for example, to the manager of the building, and I say, you know, there are individuals in this building with chronic conditions, and I wonder if you could put a message out to the community regarding the importance of wearing masks in public. So definitely, we all need to be playing a role in this. As I mentioned in the beginning, I think that we did not lead with a prevention strategy. We led with a complete panicky approach, not inappropriately, I might add, to the treatment of people who were sick. There was no time to think about a prevention campaign because we did not have a preparedness plan in place or a unit in place. There have been some PSAs, public service announcements, and other kinds of campaigns developed and distributed around the country and certainly in other countries. But I agree with you, it's not as visible as I think it should be. And that brings me, for example, now, and I'll talk about this in a second, about vaccine hesitance. That's another area that we have found issues or challenges, and early on we were not able to communicate effectively about why this was A, important, and B, safe. So thank you for that comment.
At this time, we don't have any other hands raised.
All right, well, thank you. So let me get back to where I was. Which is here. So I mentioned in my previous, no, what am I doing? I'm going back now. I mentioned that the quest for health equity and social justice was something that we need to be involved in and we need to be moving ahead with. So I just want to spend a moment in this term of health equity is thrown around in many different ways. And I just want to make sure that we all have a similar understanding of what I am talking about at this point. And I like this definition that the Robert Wood Johnson Foundation put out a couple of years ago, because it's probably the most comprehensive and it gets to all the bigger pieces in one place. So it's sometimes used in it's confused, rather, I would say, between health equity and health disparity. So I'm going to talk about this for a little bit. So to achieve this health equity that we wanted to achieve this level where people have equal access to health services and where people are able to live to their full potential, full healthy potential, it's proactive work. Obstacles need to be removed, and those obstacles that we see here in this list are often things that do not happen in the clinical setting where many of us work. So all this work really, a lot of it happens at the macro level and the macro space. And I'll talk about that in a moment as well, but there's many things at the micro level that we as individual institutions may be able to do in the short term. And this can be so many things, from providing unconscious bias training to staff, to providing babysitting services for patients for whom a barrier to access is the cost of finding a babysitter, or implementing hiring practices with an eye to reflecting the diversity of the communities being served, or in regards to the vaccine hesitancy that we have heard and read about, before going down the road of encouraging, educating, and perhaps a more effective approach would be to go behind the curtain, literally, like the Wizard of Oz. And what we may find behind the said hesitancy may be a problem, not necessarily of the horrible memories of Tuskegee, versus the reason could be that people cannot get to the place where vaccines are being offered. So can we make the vaccines come to people? These are the kinds of things that we may be able to do to try to achieve a better level of health equity as programs and institutions. The health inequities, of course, defining something by the negative is always tricky, but understanding that those health inequities refer to this uneven distribution of economic resources and therefore of the burden of disease. We all know, I'm not going to bother you with this information, but this is why are African-American infants 3.2 times as likely to die from complications related to low birth weight than non-Hispanic white infants? Or why is there a 25-year difference in the life expectancy for babies who just live a few miles away from each other? So it's important to distinguish these health disparities for health inequities, and the health disparities defined as a difference in health outcomes. And as the terms may seem interchangeable, health disparity is different from health inequity. Health disparity denotes differences, whether unjust or not, while health inequity denotes differences in health outcomes that are systematic, avoidable, and unjust. And that's a very important term to keep in mind during this time. And I am afraid this will be a similar situation. We may find ourselves in a similar situation when the next pandemic hits. And we all know that there will be, unfortunately, next pandemic. You probably all read that last week, I believe it was, there was this enormous tanker blocking the Suez Canal. And I found this image on a friend's Facebook page, and I thought it was a wonderful representation of a way of thinking that ignores the root causes of disease, right? So I'm gonna pause for a moment again and ask if there are any other comments or any other thoughts that you would like to share with us at this point.
Yes, I see Judith Maisel has her hand raised.
Hi, yes. Thank you so much for this very interesting conversation. Lately, I've been watching flocks of birds as they move throughout the sky. And it helped me to think about herd immunity, actually. But I have a feeling that that word herd immunity doesn't really mean much to if you ask I bet the majority of the population, how herd immunity can help us, I bet they would not know what you're talking about. So sometimes it's our jargon, and I can be, I can be blamed for that as well. So herd immunity, I sort of just heard it during our issues that are going on now. But sometimes it's the terminology that is used, especially, pardon me, if people are hesitant because they think herd immunity, what could that be? It sounds sort of scary, actually. So sometimes, I'm going to recommend that every organization, every institution, every school have a clinical psychologist on it to help us move through all these problems. Yeah. So it's just amazing how one discipline sometimes has a issue. I've worked in a library, so I imagined if you came into the library where I worked and used some of my library jargon, you would say, what she's talking about.
Right.
So like I said, initially, these issues are complex.
I couldn't agree more with you. Thank you for that point. I think that those of us who have been working in the health field are notoriously guilty of using language that not everybody understands all the time. I think we've gotten better at it, but certainly there's a lingo that we operate in and we sometimes have a hard time stepping away from. I think that the notion of herd immunity is particularly interesting, I'm gonna say. Like some of you probably, I have friends and relatives who are still talking about the microchip in the vaccine and how Bill Gates is gonna track us down and all sorts of pieces of misinformation abound. And one of them is about the concept of herd immunity. And it's for those who may be vaccine hesitant, and many of those I think are not even vaccine hesitant. They are perhaps more opposed to the notion of getting in their body something that from an organization that has had reputation problems, i.e. the government. So the government paid for this vaccine, it must be bad because we hate the government. So I don't think the hesitancy is about the vaccine itself. So there's an opportunity to hide behind the idea of herd immunity. I'm not going to take that. I'm just going to wait because then after all, everybody's going to be immunized and I'm not going to need to do it. So I'm going to be the winner here because I was not complicit with those horrible people in the government that created this poison they want to put in my body to track me. And this is the land of the free and the home of the brave. So I think there's a lot of that language going on, and using terms like herd immunity without really providing a simpler explanation of what we're talking about facilitates that dismissive conversation. I'm happy to talk with somebody who is unclear about that. I am happy to speak with somebody to try to understand what is the question behind the question. What is the question that people are asking about the vaccine that makes them wonder whether they should take it or not. I think that's a fairly easy conversation. I did a couple of weeks ago a webinar for the food services employees of the university. Shockingly, many of them are Spanish speakers, so I did it in Spanish. And the most interesting part was getting exactly behind those questions. If I was going to have a conversation with a person who is a devout and active anti-vaxxer, I'm probably not going to engage in that conversation because I don't think I'm just going to hopefully be able to contain myself and not lose my mind. But I don't think that's a worthwhile conversation for me at this point.
Jose Ramon, we have
Yes.
another hand up. Mark
Great.
Huffman, feel free to unmute yourself.
Thanks, Kate. Thank you very much for the discussion. Can you talk a little bit about potential political changes that could influence, I mean, really the political structure of how the United States is influences, I think, some of the disconnectedness. Illinois is a home rule state, so there's a lot of potential power at the local kind of county level for public health, and rolling that up on a national level has obviously been, hasn't worked very well throughout this. And so are there potential political solutions that might lead to better harmonization in the future? Thanks.
Thank you. And I just want to clarify that I don't know Mark, but you provided me with the opportunity to put up this slide then. I don't have the answer to your question, and I think it's an incredibly important question. And I don't know that there is an answer for everything. I think there may be a number of different answers that are valid in different contexts throughout the country because of the political nature of the country. First of all, the federation style of the republic, of the government of the republic, but also there's a series of values and beliefs that are very deeply rooted, and there are great fractures right now in the US society along political lines and beliefs. So, but there are processes and there are means to change laws or to create laws or to attempt to change the conversation along some of these parameters. APHA is holding next week its Policy Action Institute, and that's a space where a number of individuals in the forefront in the policy world and the health policy space in particular gather to talk about these matters, climate change or the federal health agendas, and how to effectively communicate across party lines. So if any of you are interested in getting deeper into this space, this is a wonderful event that's just happening. Here's the link to it. I think the enrollment is still open for this. I just lost my train of thought for a second. Oh yes, this is happening next week during National Public Health Week, which is a yearly event that happens in the first full week of April. So thank you for that point. Any other comments at this point?
I don't see any at this point.
So yes, the Health Policy Institute. I've gotten into the commercial break part of the presentation here. Another part, I said a minute ago that some of the work we can do at the local level, and a lot of the work is done at the macro level. And APHA, American Public Health Association, plays a really important role in that. To the comment, another previous comment, APHA has been working with a number of groups nationwide and recently launched an alliance for disease prevention, where we are working with over 70 members from across the United States and across disciplines and spaces, from chambers of commerce to departments of public health to funders and another number of groups, precisely to not only advocate for adequate funding for programs in the realm of public health, disease prevention, and education, but to foster collaboration at the local level or at the national level. Because we also find typically that in situations like this one, grassroots groups emerge and then larger groups emerge, and 6 entities are trying to work towards the same end and competing for the same $6 in funding, and are losing the battle because they are, instead of joining forces, they are dividing the assets available. So we're trying to foster that kind of collaboration in the space through the Alliance for Disease Prevention. Another piece that you may be interested in learning more about is the work that APHA has been doing over the past year. This is a series of 6 webinars that focus on how to work towards achieving racial equity. And this is specifically relevant matter to address as we have witnessed so much violence over the past year, not to mention just in recent weeks, the horrible attacks on Asian Americans. These webinars are available through APHA's website. Here's the link. And we gathered a number of amazing speakers to talk about not just concepts, but also the how to implement the work that we believe needs to be implemented to achieve racial equity and therefore moving us closer towards achieving health equity. Another one that you may have seen already, this has been an amazing set of webinars that APHA launched in partnership with the National Academy of Medicine. These are, I believe there are about 18 webinars so far that started, I think that the first one was on the science of social distance. And the last one a couple of weeks ago was on vaccine effectiveness and the variants of the virus. So not only were they timely, or I say were because a year ago we were wondering the science of social distance. Today we have much more evidence in that space. But as a document, as the historical evidence of how we have evolved and how we have reacted, responded, and learned from events as they emerge. This was one of those cases where we're building the plane as we're trying to fly it. Is that the metaphor? So I invite you to check these out. They're really, really good, and they are available again through this website in here. So the last commercial break here is, this is the American Public Health Association. I'm sure you know it. This is a really important organization. I've been affiliated with them for over 20 years, and I have found in it my professional home, working with peers from all over the country and all over the world on matters important to me in terms of health promotion and disease prevention. So I'm gonna stop sharing this now and stop share. I think that one of the many important lessons I have learned this year is perhaps about my own privilege and perhaps about how many layers I can rely on to maintain a fairly normal life. For example, I'm coming to you via Zoom from my apartment. My job has not been threatened in any way, shape, or form. I have that amazingly wonderful employment-based health insurance. I have a stable internet connection, so I can continue to do my work and communicate with my family in 3 different countries. The rest of the world does not experience the pandemic like I have experienced the pandemic. I have been able to retreat to a pod of 2, my spouse and myself, and experience the pandemic through an almost through the top, the dress circle of the opera sitting section. This has not been the experience in the world. This has not been the experience probably for many of you either. So it's important to take a moment to understand that A, it's not over. B, there is an enormous amount of suffering going on. There's a tremendous amount of economic loss. And we all have a role to play and to continue to play in ensuring, as I forget everybody's name, I'm sorry. It's not about just demanding that our politicians do the right thing. It's about the civility with which we communicate with each other. It's about the importance of collecting and conveying adequate and relevant and timely data on what works and what doesn't. It's important that we own up to the mistakes and to the things that we may have gotten wrong at any point in time. And it's important that we continue to stand for each other and to protect each other. As was mentioned in the beginning, Rob, you mentioned the attacks, physical, verbal, and otherwise, on public health officials, commissioners, or anybody that has tried to play a role in this pandemic is just appalling. It's just appalling. And we need to be able to say something about that. And I hope that you will join me and so many others that in doing this work. I'm sure many of you are doing that already, but it's imperative that we are aware. It's imperative that we continue to talk about the inequities that bring pandemics like this one to spread the way they do. It's imperative that we continue to talk about the social and structural inequities that permeate society and that fuel the fires like this one. And it's overwhelming. it's quite overwhelming, and we're all sick and tired of sitting home on Zoom. If you're in the hospital, you're obviously not doing that. But you have to be exhausted of dealing with this. We all need to be able to take care of ourselves, because we are the ones out there one way or another, and we need to be able to care for each other and care for ourselves. So I'm going to stop right there and turn it back to you, Rob.
Great. Well, thank you. Thank you very much, Jose Ramon. You've really enlightened us, and we do have some time for questions. Please put your questions in the Q&A box at the bottom of your screen. I'm going to start with a question concerning the whole anti-science movement. I mean, we've had anti-science people movements for a long time. I mean, there still is a Flat Earth Society. There are people who deny the Holocaust. There are all sorts of deniers, but they've always been kind of very fringe, kind of inconsequential, really, movements, if you even call them a movement. They're more blips on the screen. Where do you think this anti-science movement, which now is really quite large, how do you think it could even exist? I mean, I've read, it's the lack of funding of basic education. People are just not educated like they used to be. I mean, where did this come from? It seems rather large right now.
I share your concern. I'm deeply concerned because I think it's obvious that to me it's obvious that this is laced with political views. So it's not so much I don't believe science, it's a position. It's almost more of a part of a political position. And I don't know how you bridge that gap. I don't know why you bridge that gap when you have the leaders of sections or groups or parties, frankly, using that language to polarize a population. So, I mean, how can you politicize the use of a mask? How can it be, if I'm a Democrat, I wear a mask, and if I'm not, I don't? Because I think that this is what the conversation has come to in many cases. I don't think that I hear a lot of people saying, well, I refuse the evidence presented by the CDC because according to this study, blah, blah, blah. Therefore, I do not accept what Dr. Fauci is saying. I don't hear that, as I'm hearing, I'm from this area, I believe in my freedom, and this is why I don't accept what CDC or FDA is saying about the safety of a vaccine. It worries me. It worries me very, very much. And it worries me that I don't know how to bridge those two sides, frankly.
I'm at a loss myself. So we have a couple questions here. Mark Huffman has one. What can Northwestern do to help improve public health workforce diversity?
Wow, that's a great question. I think that the efforts we make to recruit students from communities that have been historically underrepresented in health professions is a wonderful way to start that process. I think that understanding why said students either A, don't apply or don't enroll, or B, why they don't stay in the program is an important piece to take into consideration. And at Northwestern, for example, we are a very attractive institution. And I mean, there was some data published recently that our acceptance rate is something, I don't remember the number, but very low. I don't know that I would be proud of having a very low acceptance rate, but I don't understand those things. But it's not so much about acceptance, about sustaining the students through their student experience. And that's something that we are working on in my office in general, especially for students who are interested in pursuing careers in health professions. And of course, public health is one of those health professions.
Right. Judith Maisel had a couple comments. number 45, she's not using a name. Number 45 was a leader in the anti-science movement. Yes, we know that. Better schools and an educated democracy. I guess, Judith, you sort of bought into my comment about kind of the faults we have in our current education system. And I think Jose Ramon has really already commented on that. Do you want to comment any further, Jose?
Jose Ramon, no. I mean, I agree with everything that Judith posted here. I'm looking at these questions right now. I also see
If I could,
Yeah, go ahead, Judith.
okay, thanks. As a librarian, I'm sort of an information addict. So you might not like to hear this, but I'm all over the place. So tomorrow I'm going to Stanford. The other day I was at Cleveland Clinic. So I'm at Johns Hopkins. What they have done, especially during this time of tragedy, is they make their programs available to all. So this was so wonderful today because it was so personal. But why don't we open this up to the wider university and to the public? To the public. And not only would that increase the attendance, but we are leaders here in Chicago. And isn't this what leaders do, is lead? So to keep it just within the walls of the university just doesn't make sense anymore. So I've seen a number of webinars. I've been connected for a long time, for 14 years to Northwestern. And let's open the doors and engage the community. That's my recommendation, to open the doors.
We cast a pretty big net with this and include alumni, friends of the university. I mean, it's not directed to the community per se, but I mean, it's a pretty big group that this does go out to. It's not just the university itself, but it could be better, obviously.
Yeah, so marketing, the number that is here today is inconsequential. But I've been to events where there's hundreds of people. And like I said, to open it up to the community, you are right in the heart of the city.
Yeah. I know on the Evanston campus, they have the thing called Science Cafe. Have you ever heard of that?
No, but it sounds good.
Science Cafe it's at like this kind of bar, the Firehouse bar in downtown Evanston, or just outside of downtown Evanston. And I've spoken at that about Ebola virus, the Ebola epidemic. And it's basically just what you said. It's geared matter of fact, it's just the community. It's not the university people, hardly at all. It's just the community. It's actually kind of a good experience.
Because if we don't, someone else will.
Right, exactly.
We don't open this up. Because if we think that the healthcare community, even here in Chicago, is non-competitive, I keep my eyes open. Russia's opening up a huge cancer and neuroscience is building right here on the west side, multi-million. So I think that it's, in order to push this envelope, I think really you have to bring more people into the conversation somehow.
Yeah. All right, Tim Lane, you have a comment in here. You want to give it orally yourself? You want me just to read this?
I'm not even sure I could. There's just so many great topics that have come up today. I really like to thank Jose Ramon for a very broad, mind-expanding presentation. But with the idea of what we can do, I came into science in the 80s and 90s with the War on Cancer, which was actually a Republican initiative. And so it doesn't have to be, this discussion of parties, although what's happened to that party is just an abomination that we all have to confront. And I think a lot of people have said that we need to get it back on the footing that it was with respect to science and supporting big initiatives. But with respect to a great opportunity that we have right now, maybe and looking for new partners. So the War on Cancer didn't really start to get an equity footing until the 90s, when we had 7 women senators.
Right. Right.
And they looked around and they said, we need more money in breast cancer. And they went to the NIH, and the NIH said, you give us the money and we'll decide how to do it. And they said, to heck with that. They went and found new partners. And that new partner, surprisingly, was essentially the Army. And the Army created a medical enterprise to do research, and hundreds of millions of dollars went to that exercise. And it started with breast cancer, but expanded to all sorts of things. There's a prostate arm to it. There's all sorts of things. And from that start came a change in the NIH, where they now said, we have to have community voices on all of our panels, and we have to have diversity and equity measures in our enrollment for people into clinical trials, which there had never been in quite the same way.
Right.
And we have such an opportunity right now with the diversity, these new elements that have come, diverse voices that have come into Congress, to go out, say, we have the money, we have the power, we need to find a new partner that will change the dialogue in this country. And
that, Tim, if I may, I think it's the part of our civic education and our role in civic engagement is something that I don't think we push enough. I think, for example, the fundamental notion of voter protection, voter rights protections, has to be part of our conversation as health professionals, because exactly of what you're saying, it needs to be a concern of ours to be involved in that kind of place.
I fully agree. I think you're doing great stuff, and I hope we have more opportunity to chat.
Thank you.
I think we're at the top of the hour. Maybe one more question. Henry Wasserman Teitelbaum, do you have a question? You want to state it yourself? Or I can just read it. As a Hopkins-trained public health physician who worked for 25 years in my home country of Costa Rica in surveillance of infectious diseases, I'm appalled at the politicization of the pandemic here, but also in many other countries around the world. How did we get to this place? I think this is going to take another hour, but Jose, a last comment here?
I'm going to sympathize, and I'm going to say that in my native Mexico, the situation has been completely politicized as well. And I think that if you look at the disasters that have happened in the European Union with the rollout of the vaccines, there has been over the past, 5 years, 6 years, this very heavy duty polarization along political lines that I think is affecting the way we relate to each other as people, we relate to each other as countries, and we relate to even the world and the environment we live in, and it's very alarming. That's why I think that an educated citizenry and a civically engaged citizenry is an imperative to try to stop this kind of self-destruction path. And I wanted to take Leah's question here regarding some schools have courses in community organizing and advocacy. I think that community organizing and advocacy are essential parts of the work in the space of public health and in the space of all health professions. And it's an opportunity to think of adding something around.
Yeah, I think we're going to have to close our session today. I want to thank very much Dr. Fernández-Peña for taking the time to share your insights and being provocative and getting all these questions. I hope everyone watching here will join us next month in our first Friday webinar. We'll be joined by Jude Nwokiki, Vice President of the USP, which is a scientific nonprofit organization that focuses on building trust in the supply of safe, quality medicines by working to strengthen the global supply chain. In addition, the Institute's Global Health Education Day will be taking place on Friday, June 4th, and more information will be coming. Thank you again for joining us today, and thank you again, José Ramón.
Thank you so much for the invitation. Take care.